that we get outside from the body. Okay. So this is based on the basic physiology, as I mentioned before, it can be divided into two, endogenous and exogenous. And then endogenous Cushing syndrome, it can be further classified into three, which are ACTH dependent and ACTH independent. Okay, so for ACTH dependent Cushing syndrome is cortisol, hypercortisolism due to high ACTH level. Okay, this can be seen in Cushing disease, which is pituitary hypercortisolemia. Pituitary hypersecretion of ACTH. And then we can see other than that is ectopic ACTH syndrome, which is non-pituitary cause of increase in ACTH. Okay, then next I can go to ACTH independent. ACTH independent is hypercortisolemia state that is not depend to the ACTH, which is could be due to the adrenal abnormalities, adrenal hypersecretion, such as adenoma, adenocarcinoma. Besides that, iatrogenic Cushing syndrome or exogenous Cushing syndrome also can be put under ACTH independent because it is not depend to ACTH. Okay. Okay, next is pseudo-Cushing syndrome. Okay, pseudo-Cushing syndrome is a condition where the patient has biochemical abnormalities and physical manifestation that that's similar to Cushing syndrome, but the hypercortisolemia is secondary to other causes, such as depression, stress. Okay, so it show that hypercortisolemia state, but it is not due to what we call that. It is not due to Cushing syndrome that we are talking about. Yeah. So this condition called as functional hypercortisolism, and it is actually caused by chronic activation of HPA axis, and it will disappear when the underlying disorder is resolved. Okay, so next I'll proceed to exogenous Cushing syndrome. Exogenous Cushing syndrome, as I mentioned previously, it is caused by excess cortisol or that can gain from prolonged exposure to the exogenous of cortisol, such as prednisolone, glucocorticosteroid. Okay, is that okay? Okay. Alright, so I'll proceed to the question. Does use of topical corticosteroid can cause Cushing syndrome? Does anyone want to give a guess? Hami?
I think yes.
Yes, okay. That is. So yes, it's true, but this is a very rare case. So basically, this is a case of a 5-month-old female that developed Cushing syndrome due to high potency topical steroid application by her mother. So yeah, it could happen, but it's rare. So because only low dose and low potency steroid are indicated in pediatric dermatological disorder. That's why you need to be careful, because children are at greater risk of toxicity from topical steroid as they have larger surface area. So this is the baby, the Cushing baby. Yeah. Okay, next we go to the clinical manifestation. So before we go to the clinical manifestation, we need to know what are the function of cortisol. Okay, so cortisol, it acts as anti-inflammatory, it maintains the blood pressure, it increases gluconeogenesis, lipolysis, proteolysis. It also causes decrease in immune function and also decrease bone formation. Okay, so as we know, as stated that it causes increased gluconeogenesis, lipolysis, and proteolysis. But why? Why Cushing syndrome? We look Cushing syndrome patient. They have these thin extremities and central obesity. Okay, because our body, cortisol is more sensitive to the peripheries. That's why it causes increased gluconeogenesis, lipolysis, proteolysis to the peripheries, to the extremities. And our central body part is sensitive to insulin, which is has been mentioned by Brother Hami. It is cause more to anabolic reaction. It will store more fats and so on. Yeah. So for pediatric, in pediatric, growth failure with associated weight gain is one of the most important clinical features present. Yeah. So we need to look at the growth chart of the patient. Okay, there are other common problems in the children with Cushing syndrome. Okay, and it is compared to the adult patient, Cushing syndrome presentation in the children is quite different. Okay, dia tak ada, they have no sleep disorder and so on. Yeah. Okay, this is the other manifestation. Okay, next I will go to the investigation. I hope everyone is okay. Okay, so for investigation, as I mentioned before, okay, for Cushing syndrome, we need to know, we need to remember these three. First, we need to look for the sign and symptom at the patient. Second, we need to document the hypercortisolism state. And then third, we need to look the cause of the hypercortisolemia. And now we are looking for the second one, which is we need to document the hypercortisolemia state. Okay, so for the first step, we need to look for the plasma cortisol level, and we have three ways to look for the cortisol level: urine free cortisol, midnight salivary cortisol level, and also serum cortisol level. So if this high, we cannot depend on this alone. We need to support by low dose dexamethasone suppression test. Okay, so normally low dose dexamethasone suppression test, low dose dexamethasone, it will cause suppression to the ACTH, and then cortisol level will reduce. But in this Cushing syndrome, there is no reduction of cortisol, or reduction, or there is the reduction, but it's not significant. So there are two ways. Okay, overnight dexamethasone suppression test. Okay, you can see there, and the cortisol level is still high. So when we have done the urine-free cortisol or plasma cortisol level, and we do low dose dexamethasone suppression test, and both of these show high cortisol level, then we can say that this is support the diagnosis of Cushing syndrome. So it fits to our second objective. First, look for the sign and symptom of the patient, and to documenting the hypercortisolemia state of the patient. Next, we go to the third one, which is we need to know where is the what is the cause of the hypercortisolemia. Okay, we can next we measure the ACTH level. Okay, so normally this Cushing syndrome patient, they have high cortisol level. So high cortisol level normally it will cause suppression to ACTH, and ACTH level will reduce. Then we measure the ACTH level. Okay, so when the ACTH level is low, we measure the ACTH level. ACTH level is low. It means that the cortisol is the cortisolemia state is ACTH independent, which is cortisol is high, and it's still able to cause the ACTH to be suppressed. And this is most likely to be iatrogenic cause or adrenal cause. Okay. For when we measure the ACTH level or ACTH level are high. So this means that the hypercortisolemia state is due to the high ACTH level. So this is we call as ACTH dependent Cushing syndrome. So ACTH dependent Cushing syndrome are such as Cushing disease, which is the pituitary cause, or atopic ACTH, has been mentioned before. Okay, next. Okay, before this we have ACTH independent and ACTH dependent. So now we want to know, is this ACTH dependent, is pituitary cause or non-pituitary cause? We do high dose dexamethasone suppression test. Before this low dose, right? This is high dose dexamethasone test. Okay, so when the patient normally when high cortisol level, we suppress high cortisol level because suppression of endogenous ACTH, and then ACTH level will be reduced, and also cortisol level will be suppressed. Reduced. Okay, so when there is reduction in the cortisol level, this support the diagnosis of Cushing disease, which is the HPA still intact. And then if the cortisol level is still not reduced, it means that the hypercortisolemia state, it is not due to what we call that. It is not endogenously. It could be other tumor that secrete ACTH, and then it stimulate the adrenal cortex to release cortisol. Okay. Alright, so other than high dose dexamethasone suppression test, we need to do CRH stimulation test for diagnosing of Cushing disease. Okay, CRH stimulation test. So when high CRH CRH stimulation test, as mentioned, CRH stimulation test. So we administer CRH. Okay, so high CRH level, it will cause increase in ACTH level and cortisol level. So when we measure the ACTH and cortisol level after the administration of CRH in pituitary disease, what do you think will happen? The cortisol and ACTH will increase or decrease? Someone? Hello?
Decrease.
Increase. Yes, increase. So in Cushing disease, it will cause increase in ACTH and cortisol. So when there is no response after CRH stimulation test, it means that it is ectopic ACTH syndrome. Okay, right. So this is basically the summarize of what I've been talking about, the investigation. So when we have independent Cushing syndrome, we need to proceed with the adrenal CT because we suspected for adrenal tumor hypersecretion. And then we for ACTH dependent, we can do more investigations such as pituitary MRI and so on. This is also, you can do CT scan, MRI. Okay, so principal management for Cushing syndrome is firstly, we need to reverse the clinical manifestation by reducing cortisol secretion to normal. And then secondly, we need to eradicate any tumor threatening the health of the patient. And then thirdly, we need to avoid permanent dependence upon medication and avoid permanent hormone deficiency. So basically, our management based on the cause of the Cushing syndrome. So if it is iatrogenic or exogenous, we need to discontinue or reduce the dose of steroid is possible. And if it is pituitary cause, we can do surgery, adrenal cause also surgery, and also ectopic. We can do surgical management. Yeah. So this is the last slide, I think. For the differential diagnosis for presented with Cushing syndrome can be simple obesity due to the features, generalized corticosteroid resistant, corticoid resistant. All I've been mentioned in the table, and also pseudo-Cushing syndrome. Yeah. Do you have any question? I dah habis.
Alright guys, have got any question? So basically the most commonest cause presentation of Cushing syndrome to pediatric is mainly about short statures. Sometimes it can cause short statures. It's also because it's cortisol, so sometimes cortisol can be a manifestation like diabetes as well. So cortisol can give you high blood sugar. So sometimes they can come with symptom of polyuria. But tapi it's a bit on the rare occasion. Mainly Cushing syndrome come to pediatric with kind of like short stature rather than anything else. But obviously, macam the cases of children yang ada eczema, yang ada been on long-term topical steroids. Sometimes they can come with complication of that. For example, they can come with a pseudo-hypoaldosteronism, where the child can be very cachectic, very thin, and sometimes they can have a metabolic disturbance as well, especially in sodium and potassium. So those could be a presentation of Cushing syndrome. My question to apa tadi? Aina, I don't know whether you guys been thinking about this or not. How do you differentiate between Cushing syndrome versus steroid toxicity?
Not sure that they
Ada pandangan? How do you differentiate between Cushing syndrome dengan steroid toxicity?
steroid toxicity can cause Cushing syndrome. Not sure that they.
So steroid toxicity is mana hypertension, depression, hypertension, stress, depression as well. Sometimes steroid toxicity can cause Cushing physical changes and so Cushing syndrome can be a complication of steroid toxicity, betul tak? So because it's steroid. If somebody on prednisolone for nephrotic syndrome can be on for a long time, the most commonest thing that you see in the steroid toxicity, especially hypertension dengan apa, sometimes you can get hirsutism with poor growth. So steroid toxicity can present like a Cushing syndrome, but steroid toxicity is much more bigger than Cushing syndrome, and so dia macam Cushing syndrome is a subset to steroid toxicity. Steroid toxicity can be much more than Cushing syndrome. Tapi Cushing syndrome children can have hypertension because it's all side effect of cortisol. So whether it's endogenous or exogenous, in the Cushing syndrome and Cushing and also steroid toxicity is a bit difficult to differentiate. But we know most of the patients yang on steroid they will steroid toxicity. Cushing syndrome is mainly that you see is the endogenous that you normally see, and if that particular case, then you need to investigate further. If you know the child is on exogenous, which is taking steroids, then the management is just simple, which is reducing the dose or stopping the dose or switch to other agents. So those are Cushing syndrome is more subset to the steroid toxicity. Okay, so no question, so we can move to other topics. So sekarang adalah apa? Tak ingat apa sekarang. Sekarang adalah what was it again? So diabetes, Cushing,
And hypothyroidism.
thyroidism. Thyroid.
Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Farha binti Majaha, and I will talk about hypo and hypothyroidism. So next slide. Sekejap.
So before I discuss further about hypo and hypothyroidism, let us revise about thyroid gland development. So you can see in the right picture, the thyroid gland is derived from the foramen cecum. So you can see foramen cecum. Then it will migrate down to its normal anatomical location about 8 to 10 weeks of gestation age. And then this migration is marked by the thyroid grosser duct, which normally involutes after that. So next. So these are the steps of production of the thyroid hormone. You can read it by yourself later because we already learned it. Next. And then the regulation of thyroid hormone is hypothalamus pituitary thyroid axis. So the hypothalamus will release the thyroid-releasing hormone that will stimulate the pituitary gland. Then the pituitary gland will release thyroid-stimulating hormone that stimulates the thyroid gland. The thyroid gland will release thyroxine, T3 and T4 that will have the negative feedback on the hypothalamus and the pituitary gland. So next. So there are many functions of thyroid hormone such as increase the heart rate and contractility of the heart, increase gut motility for the brain and nervous system development, bone growth and maturation, increase sensitivity to catecholamines, temperature regulation, increase basal metabolic rates and many more. But the one thing that I want to highlight from this slide is that thyroid hormone function is to promote growth and the development of the brain and the neuron during the fetal life and its first few years of the postnatal life. Next. So the etiology of hypothyroidism can be broadly divided into two, which are congenital and acquired. For most of the cases of congenital hypothyroidism, it is caused by thyroid dysgenesis. So what is thyroid dysgenesis? So it can have three manifestations. Either there is ectopic thyroid location, which is denotes of 60% of its cases. Erythrosis, which is there is no development of thyroid gland at all, and hypoplasia. And other causes is dyshomogenesis, where there is some abnormality in the thyroid hormone synthesis function, and then central hypothyroidism, which is hypothalamic pituitary hypothyroidism, where there might be defect in embryological development of the pituitary gland, or there is a mutation in the genes that are responsible for the production of the pituitary hormone. And then transient neonatal hypothyroidism, it is transient, but most commonly due to iodine deficiency, especially in the preterm baby, and if the mom takes anti-thyroid drugs. And then rarely it causes by peripheral resistance to thyroid hormone. So the acquired cause, most commonly in pediatrics, is caused by autoimmune thyroiditis, which is Hashimoto's thyroiditis. And then it may causes by subacute thyroiditis, iodine deficiency, and iatrogenic, especially radiation to the head and neck. If the patient have a tumor of the brain or the neck or Hodgkin lymphoma. So next. So these are the sites of ectopic thyroid tissue we can see in the picture. It may be in the lingual part or intralingual, or maybe sublingual or retrosternal. So next. So the clinical presentation of hypothyroidism, congenital hypothyroidism, is mostly asymptomatic at birth. But subtle clinical features can be seen, such as prolonged neonatal jaundice, which is more than 14 days, constipation, poor feeding, quiet baby, and enlarged fontanelle. But if you left untreated, which this clinical manifestation may appear after 3 to 6 months, the babies may have coarse faces, dry skin, macroglossia, horse cry, umbilical hernia, as we can see in this picture, lethargy, slow movement, delayed development milestone, poor growth, and mental retardation. Next. So this baby, we can see that the tongue have microglossia. And the one thing that I want to highlight is that hypothyroidism is one of the most common cause of preventable mental retardation. As the disease undiagnosed or untreatable, the longer the disease untreatable, the longer the IQ, the IQ will be reduced. So next. So these are some of the symptoms of acquired hypothyroidism, such as general slowing down, lethargy, somnolence, depression, modest weight gain, cold intolerance, hoarseness of voice, dry skin, constipation, and many more, as we learned before. So next. So these are much more details of the symptoms for the congenital hypothyroidism and acquired hypothyroidism, which specify in the pediatrics symptoms. But the one common thing that I want to highlight is that we can see in the acquired hypothyroidism, mostly there is a deceleration of the growth. It can be with or without short stature, and many more that you can get later on. So next. So since I said before, the congenital hypothyroidism is mostly asymptomatic, and it is sporadic cases. So we do not know who will be affected. So in Malaysia and many other countries, we have this screening program for congenital hypothyroidism in all newborn baby. So in Malaysia, we practice to get the cord blood sample, which is located at the labor room. And then this sample will be sent to the lab for TSH level. So if TSH level is normal, then which is less than 20, then it's okay. If it's borderline, then we send for free T4 analysis. And then if T4 if normal, then okay. But if it's low, the baby will not be discharged, and or if baby is discharged, we will call the baby and then refer to the pediatric clinics. And then if the high TSH level which is more than 60, then we manage by the same algorithm. And then we need to reconfirm back by taking the venous TSH and T4 level. You can see below. After 3 days of the age of the baby, because in the first 3 days, there will be physiological surge in the TSH level because of during delivery, the baby have stress, so there is increase in thyroid hormone, and also at the same time there is a transplacental passage of the TSH. So therefore, after 3 days, and then in babies, they have slightly different normal reading. Okay, next. So apart from that, we can do a thyroid ultrasound to evaluate the anatomy of the thyroid gland. So next. So for the management, for the permanent congenital hypothyroidism, they managed by lifelong levothyroxine. And this levothyroxine must be immediately administered after the diagnosis and within 2 weeks of the life. Because as I said before, if there is longer or if there is untreated, there will be the lower the IQ will be. So if features of hypothyroidism are present, treatment is to be started urgently. Since it's in the tablet form, so the tablet need to be crushed and mixed with small amount of breast milk or water, and it should not be mixed with soy formula or any preparation that containing iron, since it can reduce the absorption of the T4. So and the goals of therapy is to get normal level of free T4 and TSH level, and for the patient to have normal growth and neurodevelopment. Next. So the patient need to be followed up according to the intervals that have been provided. And then on the follow-up, we take the thyroid function test, and then we assess for their growth and development, mental cognitive function, symptoms of over or under treatment, hearing test, since thyroid deficiency can cause sensory neural loss, sensory neural deafness, and also the bone age. Okay, next. Okay, next I will talk about hyperthyroidism. So before I talk about hyperthyroidism, we need to differentiate between hyperthyroidism and thyrotoxicosis. So hyperthyroidism is overactivity of the thyroid gland itself, that lead to excessive release of the thyroid hormone. While the thyrotoxicosis is a clinical effects of the unborn thyroid hormone. It can be from the gland or it can be from anywhere exogenously, for example. So next. So the etiology of hyperthyroidism can be primary, can be secondary or exogenous. So primary, most commonly in pediatrics, it causes by the Grave disease. But it can be toxic edema or toxic MNG, subacute thyroiditis, chronic lymphocytic thyroiditis, especially Hashimoto thyroiditis in early stage, and bacterial thyroiditis. Pediatric causes of thyrotoxicosis include pituitary adenoma or pituitary resistant to T4, or it can be due to exogenous thyroid hormone. So Grave disease, as I said before, is most majority of causes of hypothyroidism in pediatrics, with the notes of 95% of all cases. And grave disease is due to T-cell dependent autoimmune disease, where this autoimmune disorder results in the production of antibody that directed against the thyroid receptor, which then, if the receptor is become activated, there will be increased release or stimulation or production of the thyroid hormone. And then it is most commonly in female. There is a term disease called neonatal grave disease, which denotes of less than 1% of the causes of hyperthyroidism in neonates. When the patient have it, usually they have maternal history of grave disease, either in the past or during the pregnancy. This is due to transplacental passage of the TSH receptor antibody, which then stimulate the thyroid hormone of the baby, the fetal. And it is rare and mostly self-limited that resolve in 3 to 12 weeks, but it can be severe and life-threatening. So the clinical features of the neonate, we can see there is premature birth or lower birth weight, irritability, hyperactivity, tachycardia, hyperphagia, increased bowel movement, and sometimes goiter. So next. So this patient, you can see the baby have signs of hyperthyroidism, the eye sign, and then look, her or his mother have the same clinical features. So other clinical features of hyperthyroidism, weight loss, despite in appetite, sweating, hyperactivity, intolerance, palpitation, diarrhea, insomnia, and many more. So next. On physical examination, for grave disease, we can find there is diffuse non-tender goiter, and then you can hear thyroid. Sometimes the patient can have tachycardia, exophthalmos, leg retraction, periorbital edema, ophthalmophagia, smooth sweaty palm, tremor, accelerated diphtheria reflex, proximal muscle weakness. So for investigation, we can do a thyroid function test to see the TSH level and the free T4 level. And then for the grave disease, patient have TSH receptor antibody. And then we can do ultrasound of the thyroid for better establishment of the size and echo characters of the nodules. For example, if there is hyperechogenicity, irregular margin, which lack of capsules, microcalcification, or increased vascularity, this might be the echo character. This is echo character of increased risk of cancer. And then we can also do FNNC if the thyroid nodule is more than 1 centimeter, or if it less than 1 centimeter, with ultrasound features that suggest suspicion of thyroid cancer. And then we can do chest X-ray if there is clinical evidence of thyroid deviation or retrosternal extension to see for it, okay, to confirm. So for management, so mostly, as I said before, hypothyroidism in children is caused by grave disease. So in children, we manage by pharmacological or surgical, but mostly they have high remission rate for pharmacological. So we give anti-thyroid drugs such as methimazole, and then beta blocker if there is increase in heart rate or palpitation. But PTU is no longer recommended as a first-line drug in infant because it can cause acute liver failure. So we need to avoid it as much as we can. If you cannot avoid it, then we need to. Okay, that's all from me. So this is my references. So any questions?
So let's just go back to the previous slide. Okay, so management of kalau macam hyperthyroidism so kalau hypothyroidism then you just replace with thyroxine, which is quite easy, especially for the congenital hypothyroidisms. For the hyperthyroidism, which is you using anti-thyroid medications, the most commonest one is methimazole. My question is, what is the mechanism of action of beta blocker in treatment in treating hyperthyroidism?
So in patient with hyperthyroidism, they might have hyperadrenergic stimulation, because as we know, the thyroid hormone function is to it has permissive action on the noradrenaline and the adrenaline. So patient can have palpitation, tremor. So in order to reduce the action, so we can give beta blocker. And also beta blocker also have they inhibit the peripheral conversion of T4 to T3. So there might be reduce in T3 level, which is the active stage of the thyroid hormone. So that's the mechanism.
Yep, good. So yeah, so there is anti-thyroid kind of components in the beta blocker, especially sometimes if you got tremors. So if you got tremors, sometimes beta blocker is useful as well. And as part of the hyperthyroidism, so sometimes hyperthyroidism also can cause hypertension, kan? So beta blocker also works for that as well. So apart from blocking the T3s, from the blocking the thyroid kind of receptors, it also can reduce the hyperthyroidism symptoms. For example, hypertension, tremors. Sometimes it's useful for headaches as well. Sometimes with the hyperthyroidism, you got headaches as well. So beta blocker is a good, useful medication, mainly for the symptomatic management. Okay, because metimazole metimazole lebih kepada try to destroy or try to reduce the production of thyroxine, or reduce the excessive production of thyroxine. Beta blocker is more towards managing the symptoms of excessive thyroxine. So that's mainly lah. Tapi first line you go for metimazoles. If metimazole does not really with metimazole tapi ada macam symptom of hyperthyroidism, then you can add on beta blocker after that. Okay, any question about these topics? Okay, if no question about this topic, I think we go for the last one, which is rickets.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Can you guys hear my voice? Anyone?
Yes.
Yes.
Okay. If my voice tersekat-sekat, sorry sebab my connection doesn't want to cooperate with me, so it's okay. So next. Okay, so this is the outlines for my part. Next. Okay, so what is rickets? So according to the illustrated textbook of pediatrics, rickets mean failure in mineralizations of the growing bone or osteoid tissue. Meanwhile, Nelson textbook of pediatrics define rickets as disease of growing bone caused by unmineralized matrix at the groove plates in children only before fusion of the epiphyses. Next. Rickets mainly occur as a result of the vitamin D deficiency. So the same thing happened to the osteomalacia. So how can we differentiate between these two diseases? Basically, rickets is a disorder of growing bone, but osteomalacia is a disorder of mature bone. Rickets, it can be found in the children, but osteomalacia, it can be found in the adult and post-pubertal adolescents. And rickets, it's occur due to defective mineralizations of the growing bone, and osteomalacia occur because of inadequate and delayed mineralizations of osteoid in mature compact bone. Next. In terms of epidemiology, there is increased evidence of vitamin D deficiency worldwide, resulting in nutritional rickets in children. And the increment of worldwide incidence also related to use of sunscreen and implementations of other sun protection behavior. So basically, rickets is prevalent in Africa and Asia due to limited sources of vitamin D and calcium. And there were studies done in 2008 on primary school students in Kuala Lumpur, revealed 35.3% had vitamin D deficiency. Next slide. Okay, so as I said earlier, rickets occur due to inadequate of the vitamin D. However, other causes such as calcium and phosphorus deficiency also can contribute to rickets. Next slide. Okay, just a quick recap about the metabolism of the main culprits of rickets, which is vitamin D. So cholecalciferol, which is vitamin D3, is produced by ultraviolet irradiations of inactive precursors in the skin, while ergocalciferol, which is vitamin D2, is derived from plants. So this vitamin D2 and vitamin D3, it require further metabolism to become active. So they will be metabolized by the 25-hydroxylase in the liver into calcidiol or 25-hydroxy vitamin D. Then this metabolite will be transported by plasma binding globulin to the kidney, where it will be converted by 1-alpha hydroxylase to the most active metabolite, calcitriol or 125-dihydroxy vitamin D. So what happened that? So this calcitriol, it will increase the blood calcium levels by promoting absorptions of dietary calcium from the intestine, and it will increase renal tubular absorptions of the calcium. Then this calcitriol also will stimulate release of calcium from bone. Next slide. Okay, so vitamin D disorders include nutritional vitamin D deficiency due to poor vitamin D intake, exclusive breastfeeding into late infancy as breast milk contain low vitamin D, and inadequate cutaneous synthesis because of ineffectiveness of the winter sign, avoidance of sunlight because of concerns about cancer, and because of increased skin pigmentations. Next, congenital vitamin D deficiency occur due to severe maternal vitamin D deficiency during pregnancy as a result of poor dietary intake, lack of adequate sun exposure, and closely spaced pregnancy. Secondary vitamin D deficiency result from intestinal malabsorption syndrome such as celiac disease and Crohn's disease. And because vitamin D is a fat-soluble vitamin, so its absorption may be decreased in patients with variety of liver and GI disease. Next slide. Calcium deficiency occurs because of inadequate dietary calcium due to less intake of dairy product, which is the main dietary source of calcium after started weaning, milk allergy, and during transition from formula or breast milk to juice or calcium-poor soy drink without alternative source of dietary calcium, as this formula and breast milk are excellent sources of calcium. Malabsorption of the calcium also can occur in celiac disease and post-small bowel resection, which may be concurrent with malabsorption of the vitamin D. Next slide. Phosphorus deficiency happen in starvation or severe anorexia due to low intake, and it can be also due to long-term use of aluminium containing antacid, as it is very effective at chelating phosphate in the GIT, leading to decreased absorptions, and it can be due to renal loss, as in the case of X-linked hypophosphatemic rickets, autosomal dominant hypophosphatemic rickets, and autosomal recessive hypophosphatemic rickets. Next. So this table summarizes the causes of rickets, which I have mentioned just now, so you guys can read later. Next. So in terms of pathophysiology, rickets occur due to inadequate dietary intake of vitamin D or due to inadequate exposure of the sunlight, which can cause insufficient active vitamin D. So because of that, calcium absorption from the intestine, which is dependent to vitamin D, will be diminished, causing hypocalcemia. Next. So this hypocalcemia will then stimulate excess secretions of parathyroid hormone, which in turn cause calcium mobilization from the bone. So and it will also cause increased renal reabsorption of the calcium and increased renal excretion of the phosphate. So this will cause negative calcium and phosphorus balance, thus decreased mineralizations of the newly formed bones, as the two principal substances necessary for bone mineralizations are calcium and phosphate. Next. So these are the 10 important clinical features in rickets, which include delayed closure of fontanelle, white sutures, frontal bossing, craniotapes, dental hypoplasia, rachitorocery, pectus carinatum, Harrison sulcus, swelling in wrist and ankle joint, and bowing of legs. Next. Okay, so please appreciate of this picture. So the first picture, which is the craniotapes, is a softening of the cranial bones, which manifests early and can be detected by applying pressure at the occiput or over the parietal bones. So if you guys are playing the ping pong ball, so you guys will appreciate these craniotapes. So the sensation is similar to the feel of pressing and releasing a ping pong ball. It is a normal finding in many newborns, but typically will be disappears within a few months of birth. If rickets occurs at a later age, thickening of the skull will develop, producing frontal bossing, as you can see in the second picture, and delay closure of the anterior fontanelle. Widening of the costochondral junctions result in rachitorocery, which you can see in the third picture, which feels like the bits of rosary when moving along the costochondral junctions from rib to rib. Next slide. Okay, so horizontal depression along the lower anterior chest is known as Harrison sulcus, which you can see in the first picture, which occur from pulling of the soft ribs by the diaphragm during inspiration. So this opening of the ribs also will impair air movement and predispose patient to the atelectasis and pneumonia. And because the rickets soften the areas of growing tissues at the end of bones or growth plates, it can cause skeletal deformities such as both legs or knock knees in the four pictures, also thickening of the wrists and ankles in the third picture. Softening of the long bones, it may bend, causing fracture on one side of the cortex, which is green stick fracture as shown in the second picture. Okay, so next slide. Okay, so this is the summarizations of the clinical features of the ricket, which is very important to look during physical examinations. Next. In terms of diagnosis, so ricket basically diagnosed based on presence of classic radiographic abnormalities, which is then supported by history, physical examination findings, and laboratory results consistent with specific etiology. Next. So if you have met patient with rickets, so these are the list of questions that you need to ask. So the initial evaluation should focus on the dietary history, emphasizing on both vitamin D and calcium intake. High dietary fiber interfere with calcium absorptions. And then cutaneous synthesis mediated by sunlight exposure is one of the source of vitamin. So do ask about time spent outside, clothing, especially if there may be a cultural reason for increased covering of the skin. For example, in Muslim, we need to cover our aurat and winter sunlight. So presence of maternal vitamin D deficiency need also to be considered when unit or young infant has rachitic findings, especially if the infant is breastfeed. And child's medication use is relevant. For example, like phenytoin, it can increase degradations of the vitamin D, or aluminum containing antacid, which is a phosphate binder. Malabsorptions of the vitamin D suggested by history of liver or intestinal disease, and ask also about history of renal disease as chronic kidney disease. It also can cause rickets. Children with rickets, they might also have history of dental caries, poor growth, delayed walking, waddling gaits, pneumonia, and hypocalcemic symptoms. And family history is also important for genetic causes of the rickets. Next. Okay, so for the physical examination, it is important to focus on detecting manifestation of the ricket based on the table that I have shown just now. It is important to observe the child's gait, plot the patient's growth, auscultate the lungs to detect atelectasis or pneumonia, and look for any bone tenderness and abnormalities. Next. Okay, so laboratory tests in child with rickets should include serum calcium, phosphorus, alkali phosphatase, parathyroid hormone, calcidiol, calcitriol, creatinine, and electrolytes. Urinary excretions of the calcium, which is 24-hour collection for calcium or calcium creatinine ratio, is helpful if hereditary hypophosphatemic rickets with hypercalciuria is suspected. You guys can refer to this table for interpretations. Next. Okay, so characteristic radiographic changes in rickets children compared to normal, as you can see in the picture here, include transformations of the edge of metaphysis from convex or flat to a more concave surface, which is known as cupping, and it is most easily seen at the distal ends of the radius, ulna, and fibula. Another changes that can be seen is fraying, where the edge of metaphysis loses its sharp border. Next. So this is the radiographic finding of bowing legs. Next. Okay, among the complications in rickets are failure to thrive, severe skeletal deformities, hypocalcemic seizures due to severe vitamin D deficiency, and dental defects due to poorly formed dentin secondary to vitamin D deficiency, and close proximity of the pulp to the tooth surface causing rapid necrosis. Next. So the principles of therapy in rickets patients include vitamin D supplementations, treat underlying causes such as calcium and phosphorus deficiency, and also preventive measures by giving vitamin D supplementation for pregnant women with documented vitamin D deficiency by 200 international units per day, and for neonates and infants by universal administration of 400 international units in less than 1 year old, and in older children we give 600 international units. Next. So the treatment for vitamin D deficiency comes in various preparations, dosage, dosing schedules, whether it is single or multiple dose, and administration routes, whether it is oral or intramuscular. And for symptomatic hypocalcemia, IV calcium is initially given as an acute bolus with transitions to enteral calcium. For calcium deficiency, treatment will focus on providing adequate calcium, typically as dietary supplement. Vitamin D supplementation is necessary if there is concurrent vitamin D deficiency. In phosphorus deficiency, patients will respond well to combinations of other phosphorus and calcitriol. So the daily need for phosphorus supplementation is 1 to 3 grams divided into 4 or 5 doses. This frequent dosing helps to prevent prolonged decrement in serum phosphorus because there is rapid decline after each dose. Next. So this is the most exciting part because it is the last slide. So the prognosis of the ricket is excellent, especially when diagnosed early. Many of the bone malformations improve dramatically, for example, like bowing legs that may resolve over years without surgery. However, beware in children with severe disease, they may have permanent deformities and short stature. Next. So this is the list of reference that I have used. So that's all from me. Thank you.
Right, thank you very much. Let's go back to the very early, the epidemiology, I think. Aha, okay, fine. So siapa tadi? I can't remember your name. Aiza kan?
Yes, yes.
So you're talking about sources of vitamin D, which is the sunlight, the diet, and the last one was, I can't remember what was the last one. Lupa. The sources of vitamin D. Can't remember the other one. Okay. If you're looking at the money, if your resources is illustrated textbooks and also the Nelsons, okay, so they are basically based on the Caucasian population, and so not really much of global in term of Asian countries and also African and also Middle East countries. But bear in mind, there's still a lot of colored people in American, UK and European countries. To be honest, the main source of vitamin D is the sunlight. The sunlight is the main source of vitamin D. Despite you been taking diets of high rich calcium and also vitamin D diets, the main source of vitamin D is the sunlight, because you need to get the activation of vitamin D and D from the inactivated form to the activated form, and that's only can be done by activation through the sunlight, which is the it will be activated on the skin. So if you've been drinking or eating vitamin D, kalau tak ada sunlight, then your vitamin D is useless. So you need the sunlight for the active form of vitamin D. The reasons that why Asian population is much higher prevalence of rickets and so on is because of the lack of vitamin D, lack of sunlight exposure. Mainly because of kita punya cultures, religion punya point of view, because we tend to protect our skin due to ritual practice. So kalau kat UK pun ataupun European and also American countries, there's more of rickets due to in colored people rather than Caucasian population. Because Caucasian, when they go out, they expose their skin for sunlight. There's also increased evidence of congenital rickets ataupun not congenital, lebih kepada hypocalcemia in neonatal periods. So mak dia pregnant, obviously in pregnant ladies you need to have much better vitamin D uptake and also much better calcium uptake. But because of the less of exposure to sunlight and a poor diet and so on, so you end up with a maternal low vitamin D levels, and that can cause problem to the babies, because sometimes babies can have tetanus and also seizures due to low calcium levels in the neonatal period due to maternal low vitamin D. And vitamin D is very important. Vitamin D is an antioxidant. It can help baby growing. It can help brain maturation. It can also help in terms of gaining weight as well. So it's very, very important to make sure that mom, pregnant lady has a good vitamin D levels. And remember the vitamin D levels, vitamin D in pregnancy, especially those yang ada eclampsia ataupun hypertension, pregnancy-induced hypertension. Some study says infusion of vitamin D can improve placenta functions in preeclampsia. So vitamin D is orang kata antioxidant that probably help in lot more pathology ataupun in many conditions nowadays. Cuma the trials, the practice, the evidence is not that robust to support the practice at the moment. But what we know so far is vitamin D is related to calcium and rickets. Cuma for other conditions, it's not that the evidence is not that robust. Okay, so as you mentioned in 2008, which is a very long study. Ini the old study in 2008 ni. Kalau nak betul-betul current punya study, nak kena ambil yang much more updated. 2008 ni dah lama. Tak tahu lah if you can find 2018 ke 19 ke 20 ke about vitamin D levels. And plus this is primary student in KL. So I presume that most of the children nowadays, even you guys pun pagi-pagi bangun pagi, mandi-mandi, get ready and then go to hospitals. And I don't know whether you guys get ready by 6-7 o'clock and then went for jogging dulu and then barulah masuk kelas kan. So nowadays people just tired after classes, and medical student has been burnt out with a lot more attachments, a lot more coursework, and also a lot more things to do. And you guys are too busy to do exercise in the morning. So lah. And then the best time for exercise is not 7 o'clock, not 8 o'clock in the morning. And the best time is what is the best time for the sun exposure for your vitamin D activation? What time? 8 to 9 ke? 8 to 9. Kenapa 8 to 9?
Matahari baru naik.
paling kuat cahaya.
9 o'clock.
9
o'clock.
Just nice.
Just nice.
Waktu duha.
Waktu duha. Alhamdulillah, Masya Allah, waktu duha. Okay, so do you know what components of sunlight that actually required for the vitamin D activation? Is UV ray kan, UV light kan, betul tak? Betul tak? Agree kan? Okay, so obviously sebab kita duduk dekat equatorial, which is khatulistiwa. So different places depend on the altitude and also latitude. So different latitudes and also altitude give you different timing when exactly the abundance of UV light will be. So in early morning 7, 8, 9 ke, the UV light is not that abundant. And tapi dia depend pada which country you live lah. Okay. Kalau macam if you go to the north hemisphere, so the best time for UV light is basically afternoon. Mana dia punya UV light dia lagi banyak masa mungkin dalam pukul 1, 2, 3 untuk lebih kurang. So for us in Malaysia, because you are in the equatorial, so the best time for the better ataupun for the abundant amount of UV light is basically after 10. But in the morning sunlight baru nak naik je. nak naik. So UV light tak banyak lagi. So dia akan banyak bila dah matahari tu dah almost reaching the perpendicular punya degree. So about 10-11 o'clock. But obviously you guys don't really exercise at that time kan. Otherwise you guys will be missing classes and so on. Okay. So cuma you don't need to spend 1 hour 2 hours macam sunbathing for vitamin D. You just need couple of minutes, not even half an hour, probably about 10 to 15 minutes. Just a brief exposures. Obviously lah, tak tahulah kalau orang lelaki senang lah. You got short sleeve and then you can go out. Kalau perempuan mungkin nak kena ada transparent punya clothes so that you can expose your skin. But that is something technical lah. Okay. So those are the in terms of the best way, the best time for sun exposure untuk activation of vitamin D. But apart from that, vitamin D pun banyak jenis kan. Sorry, recap pun banyak jenis. You got the X linkage in terms of hypophosphatemias. You got metabolic ricket as well. So there's plenty more of ricket that need to be tapi benda tu very difficult kadang-kadang nak detect. But I hate rickets because rickets can be, well, the main causes of rickets is a diet and also sun exposure. But when it comes to the metabolic rickets ataupun X-linked yang pelik-pelik tu, it's going to be quietly difficult to manage ataupun difficult to diagnose. But I think for the time being, I think you just need to focus on the vitamin D and also calcium update rather than anything else. Okay, any question? Okay, so me myself, I've not seen neonatal rickets, so I've not seen the cranial taps in my life so far. But obviously the bowing of the legs is almost pathognomonic in rickets, and obviously most of them kalau dia datang dengan delayed walking, and then when you examine the child they have bowing of the legs, then you need to think about rickets. And sometimes ricket can come with sounds like accidental and then sounds like non-accidental injury ataupun non-accidental fracture, but if it is fit all the criteria for rickets, such as frontal bossing, sometimes they can have delayed development as well, and also bone of the legs, and you need to think about rickets. And when you do the X-ray of the bone, you can see the osteopenia looking bone, which is quite prominent. The apa tu yang dia punya rickety rosacea tu sometimes very subtle punya sign. So sometimes it's not that easy to see that signs. Okay, and the question,
Doctor. About the cranial tap. This is due to the softening of the cranial bone, right? So when we press the child's head, and then can the soft part,
so dia akan bounce back lah. So dia akan come back to normal. The thing is, I've not seen this kind of tap before, so I don't know how long it takes to bounce back. I don't know whether it takes just few seconds to bounce back ataupun it will take some days or weeks to bounce back. Tapi people say it's like a ping pong ball, as Aiza mentioned before. So ping pong ball, I suppose it should come back almost immediately. I don't know. Ada jumpa dalam YouTube tak? Kalau if you go dalam YouTube boleh juga nak tengok, because I've not seen that before. Yeah. But cranial tap is basically congenital ricket. But to be honest with you, if mom's diet is very good, with calcium and also vitamin D, baby shouldn't have rickets. unless you're talking about yang metabolic calcium disorders ataupun macam genetics calcium disorders, then that's different. Okay, I think that's all. So some of you will have a long case discussion with me at 10 o'clock. So I think we can get a 10-minute break before we start the sessions. So if there's no question, then we're going to adjourn the session with 30 for someone else. Okay, thank you very much. So I think for the session at 10 o'clock, kita just keep the line on and then come back at 10 o'clock. Boleh?
Okay, Doctor. Boleh.
Okay, right.
Thank you, Doctor.
Thank you, Doctor.
See you in a bit.
Thank you, Doctor.
Okay, Doctor.